In this lecture, we're going to look at the digestive system. The digestive tract, also called the alimentary tract or alimentary canal, and it's also called the GI tract, which stands for gastrointestinal tract. There's going to be many accessory organs, and those are going to be primarily glands. The regions of the digestive system are the mouth or oral cavity, the pharynx, the esophagus, the stomach, the small intestine, the large intestine, and that planet near Neptune, yes, you guessed it, Uranus. So, the functions of the digestive system, we have ingestion. Don't confuse that with indigestion. That comes later after ingestion, depending on what you eat. Ingestion is the introduction of food into the stomach. And then mastication is chewing. And then propulsion, we have deglution, which is swallowing, and then peristalsis, which moves material through the digestive tract. And peristalsis is kind of a milking action. So you get waves of contraction by the smooth muscle within usually the gut, and that's what's going to propel the food to where it needs to go. You'll also get peristalsis in the esophagus to propel the food basically to the stomach. So theoretically, don't try this because I'm not going to be responsible for you choking if this doesn't work. But theoretically, you can do a handstand and swallow some food, and it should make it to the stomach. So again, don't try this because chances are it won't work for you and you will wind up choking. So, but again, think of peristalsis as a milking action. And this is why sometimes if you get abdominal pain, that colicky pain, and again, that word colicky kind of, I think of referring to colon, right? Think about like a gas pain. All of a sudden it comes on pretty strong, it eases up, and then you might get another wave and it comes on strong and then eases up. And that's because every time it comes on strong, the muscles are contracting, and that wave is going over, if it's gas, it'll be going over a gas bubble, or it might be, I don't know, with constipation, it might be hard digested matter, again, that the intestine, the irritated intestine, might squeeze over. And then once that wave passes, the pain stops as well. And then within the gut, we have mixing. This is segmental contraction that occurs in the small intestine. We have secretion to help lubricate, liquefy, and digest. We have digestion, and of course, digestion is mechanical and chemical. Mechanical digestion is when we put the food in our mouth and we start chewing and breaking it up into smaller pieces. And why do we do that other than trying not to choke to death? Well, we're breaking that food up into smaller particles, which increases its surface area. So the more surface area you have, the more the enzymes or the chemical digestion can take place. So, and then chemical digestion, like I said, would be like enzymes, which, by the way, starts in the mouth. We have amylase, which breaks down starch, being secreted by the salivary glands. So it'd be salivary amylase. And when food gets down to the stomach, there's also hydrochloric acid. So that's going to be another chemical breakdown of that food. Basically, we want to break it down into its smallest particles, such as taking proteins and breaking them down into amino acids, taking sugars, breaking them down into disaccharides and eventually to monosaccharides such as glucose in order to be absorbed and utilized. And we have absorption. This is the movement from the digestive tract into either the circulation or into the lymphatic system. And basically the lymphatic system, we're talking about certain fats. Some fats will go into circulation. Other fats go into the lymphatic system. And then we have elimination, which is waste products are removed from the body. Now, looking at the digestive tract, we've got a few primary layers here. We have the mucosa, which is the innermost layer. And in the mucosa, we have the mucosal epithelium, which is typically columnar epithelium, simple columnar epithelium. And then we have what's called the lamina propria, which is kind of this middle layer. And then we have the muscularis mucosa. Now, what the muscularis mucosa does is it forms all these little folds within the mucosa. And what's the purpose of these folds? Well, to increase surface area. Again, the more surface area you have, the more contact foodstuffs will have with the digestive wall, and the more nutrients can be absorbed. Next, we have the submucosa. Within the submucosa, we're going to see glands. We're going to see some blood vessels. And then we have what's called the submucosal plexus. This is a plexus of nerves. It's a nerve network. Okay, and the submucosal plexus will help with glandular secretions, also innervate the muscularis mucosa here to again maintain these little waves. In certain parts of the intestine, we call that the plica circularis. And then, so that's submucosa. Then we have our muscularis. And in the gut, we typically have 2 layers of muscle. When we get to the stomach, we have 3 layers. In most of the rest of the digestive tubes, we have 2 layers. We're going to have a circular muscular layer, and then we're going to have a longitudinal muscular layer. And this is what's going to help with peristalsis and that segmental mixing and things like that. Okay. And we have a mesenteric plexus there. And so the muscularis, then again, the peristalsis and what have you, will be controlled by the mesenteric plexus. Okay. And then finally covering the gut tube, basically, is the serosa. And it has a connective tissue layer, and it also is part of the peritoneum. Digestive system regulation. Nervous regulation involves the enteric nervous system, and the types of neurons are sensory neurons, motor neurons, and interneurons. And those sensory neurons, basically the gut feels, as far as sensation, is going to feel pressure and pain. Okay? But it's also going to detect, that the stretches in order to either cause like a rebound contraction over, the mass that's moving through it, or what have you. And then motor neurons, of course, are going to, again, keep the folds within the gut tube to increase surface area, but also, like we said, the muscularis layer to allow for peristalsis to take place. And then the interneurons are going to connect the neurons, and those oftentimes we will find within the reflexes. So there are gut reflexes that we'll be taking a look at later. And as I said, coordinates peristalsis and regulates local reflexes. chemical regulation, we have production of hormones such as gastrin and secretin, and then also production of paracrine chemicals such as histamine, which help local reflexes in the enteric nervous system control digestive environments such as pH levels. The peritoneum and mesenteries. So the peritoneum, we have a visceral peritoneum, which covers the organs. Remember, viscera means organs. And we have a parietal peritoneum. Think of perimeter with parietal. It covers the interior surface of the body wall. Now, some organs are going to be behind the peritoneum, and we call those retroperitoneal organs. And some of those retroperitoneal organs are going to be like the kidney, the pancreas, the duodenum, the bladder, the rectum. So again, if we opened up the abdominal cavity, we move the organs out of the way, we typically would not see those organs because they would be behind the parietal peritoneum. So we would have to cut through or remove that membrane in order to see those organs. And so the mesenteries, their function is to route vessels and nerves from the body to the organ. So it keeps them kind of organized. And we also find what's called the greater omentum and lesser omentum. The greater omentum hangs down over the intestines, and it almost looks like an apron. As a matter of fact, the way it's connected, it connects to the edge of the stomach and to the transverse colon, and you can actually take that mesentery and lift it up like you would like an apron. Now the lesser omentum is going to be found between kind of the top of the stomach and the duodenum, and that's a much smaller omentum. Looking at the oral cavity, we have the mouth or the oral cavity, we have the vestibule, and this is going to be the space between the lips or cheeks and alveolar processes. The alveolar processes are going to be the bumps that you feel on the gums. If you remember studying the skull, you'll see the alveolar processes. Those are formed by the roots of the teeth being pushed into either the maxilla or the mandible. And then lips, and the term for lips is labia, and the cheeks. So we see the upper lip or labium, and then here's the frenulum of the upper lip. It's some connective tissue, or some, I should say, some tissue connecting the lip to the gums. And then here's the frenulum of the lower lip. And of course we can see the insides of the cheeks off to the side. Now when you stick out your tongue and say ah in the back here, we're going to find the palatine tonsils. These are basically lymph nodes, and that's the reason why if you get an infection, these tend to swell. And sometimes that can interfere with digestion if you're unable to swallow your food because of these enlarged tonsils. Now the tongue is involved in speech, taste, mastication, and swallowing. And we can see there's also a frenulum of the tongue. And again, that helps to connect the tongue to the floor of the mouth. And so let's just take a look at some of the other anatomy here. We have the hard and soft palates. The hard palate, if you remember, is made up of the maxilla and the palatine bone itself. Beyond that, we see the soft palate. One thing that we do in the hospital is when we do have somebody stick out their tongue and say, ah, we're mainly doing not only an oral check, but we're also checking cranial nerves. We're looking to make sure that that soft palate goes up. We're making sure that it goes up evenly. And then when you stick out your tongue, we're also checking to make sure your tongue sticks out evenly. If it sticks out and deviates to one side, again, this could be some neurological issues going on, as well as if the roof here did not raise evenly. Okay. And moving along here, we see the openings of the submandibular duct. And so this is going to be one of the glands, the submandibular salivary gland. And these are the two little ducts just underneath the tongue. If you've accidentally or maybe purposely squirted saliva out, at somebody or on something, then this is where it's coming from. Okay, from these submandibular ducts. And that gland is going to be back by the angle of the mandible, kind of up under the jaw there. And then those ducts come forward and then underneath the tongue. There are sublingual salivary glands as well. They're going to be right up under the tongue, and the openings are going to be smaller and just go along the edge of the tongue on each side, again underneath the tongue. And let's see, we have what's called the fauces, which is the opening here. We have the uvula that kind of dangles down. Function of the uvula, it's almost like the epiglottis. The epiglottis closes to keep food from going down into your larynx and into your lungs. Well, the uvula, when you go to swallow, it actually helps to seal off the nasopharynx so that you don't blow your milk and spaghetti out through your nose. Once again, there are YouTube videos that show that, I believe. And then teeth, we have two sets of teeth. We have the primary teeth, also called deciduous teeth, milk teeth, or I grew up calling them baby teeth. And so we find these in childhood. As the permanent or secondary teeth start to mature and grow, they start eroding the roots of the deciduous teeth until finally they become loose and you pull those teeth. Now that term deciduous, you might have heard that before, talking about trees. Deciduous trees are what kind of trees? They're not evergreens. Deciduous trees are trees that lose their leaves. So the leaves fall off. Well, these are deciduous teeth. They are shed at a certain time. Okay. And so the permanent teeth in an adult should be 32. There, of course, are discrepancies. Some people do not develop all the teeth, and oftentimes the wisdom teeth, the back molars, oftentimes can develop late, and they can start causing some issues with the jaw and with the bite. And many times you might have to have those pulled out or removed, as my dentist tells me every time I go in there. I don't know how many referrals for oral surgeons I have gotten, but I guess I should have had that done. So looking at the front here, we have the incisors. Now, what does incisor sound like? Sounds like scissors, right? And if you think of scissors, the way they work is you have two blades that go past each other, and it creates a shearing effect. Well, the incisors do just that. The top incisor should go over the bottom incisor and act to shear food. Okay. Then we have the canines, or what we used to call your eye teeth, and those are typically more pointy and for grabbing and tearing. So, if you have a tough piece of meat, or if you like beef jerky, grabbing a hold of that and giving it a tear, the canines help to hold it. And then if you notice that the molars over here and the premolars have flat surfaces, those are going to be for grinding. So the fact that we have molars for grinding, we have canines for grabbing and tearing, and we have incisors for shearing, that tells us a little bit something about the human diet. The human diet, we are omnivores. So we can eat meat and we can eat vegetation, okay, vegetables. If you look at, say, a dog or a cat's back teeth, you're going to see that they're very pointy, all the way up to the canines, and their incisors typically are very underdeveloped. They tend to be pretty tiny. Okay, so they are more carnivorous. Whereas if you look at other animals, such as say a horse, for instance, or a deer, most of their teeth are flat, except for in the front. There's some incisors, again, for tearing and ripping, and the rest are the teeth are for grinding. Something like a bear has teeth much like ours. There's going to be incisors in the front, there's going to be canines, and the back molars are flat. So they are omnivores. Okay, looking at the anatomy of teeth, we have basically from here on up is going to be the anatomical crown. Okay. But from the gums, also called gingiva, so you can see here gingiva. You've probably heard the commercials for gingivitis, and that's inflammation of the gums. But from the gums up is going to be the clinical crown. Okay, so anatomical crown, clinical crown. Now, pretty much from the gums to the end of the crown here is going to be the neck. Okay. And below that is going to be the root. And let's see, we'll follow along here. We've got these periodontal ligaments. We also have something coating the tooth called cementum. There it is, cementum. So there's the cementum. And that is something that the periodontal ligaments are hanging on to. Now this is actually part of the skeletal system. This is actually a joint. Okay, remember learning about the different types of joints. This is what we would call a peg joint or a gomphosis. I find it pretty easy to remember because I think of, oh, these are gums. This must be a gomphosis. No, it's not a gomphosis. It's a gomphosis. But that's how I remember. Now, at the tip of the root, we have an opening, a hole. This is the apical foramen. And that hole is the exit point or entrance point, depending on which vessel is going into or leaving the root, but it goes through the root canal. Okay, and then the inside of the tooth has a hollowed out area called the pulp cavity. And here we're going to find blood vessels and nerves. Now, if you've ever had a root canal performed, what that is if you have a cavity or something where bacteria can get into this pulp cavity. What do bacteria like? They like warm, they like dark, they like lots of organic matter to feast on. That's, if you take microbiology, that's basically what the incubator and the petri dishes give to the give to the bacteria in order to culture them. And so right here, you have your own living built-in petri dish. Okay, so you're going to get organic matter in there. You're going to get food in there. You've already got your blood in there and some nerves. So this could be a problem. So what they have to do is make this inhospitable to bacteria. So they have to go in and they're going to have to remove all of this material. So all the organic matter, any type of infection or inflammation has to be removed, and this whole area has to be dried out. So they have tiny, tiny little tools. Well, the tools are kind of big, but they're very thin tools to be able to go down into the root canal and scrape and clean and dry all this out. Okay? No fun. I haven't had that done, and I've heard that I probably wouldn't want to have that done. Okay? Now, what's the tooth made of? Dentin is this porous material. Okay, so the dentin is very porous, and it's covered with enamel. Now, enamel is very tough. Enamel is the strongest substance in the human body. Okay. Now, on top of the tooth made of enamel, we're going to find cusps. Okay. And then salivary glands. Produces saliva, and saliva does a few different things. It prevents bacterial infection. It helps for lubrication. If you've ever had a dry mouth and you've tried to swallow food, you know that's not a good thing. And it contains salivary amylase, which again breaks down starch. Now, there are 3 pairs of glands. You have the parotid glands on the side. Now, how I remember this, because I like to, draw little pictures to help me remember. So if something sounds like something, I'll draw a little picture of it to remind me. So I used to draw it like a little parrot sitting on the side of somebody's face. So that reminded me that that was the parotid gland. And then there's a duct coming off of that called the parotid duct. And that goes on to the inside of your cheek. I don't know if you've ever noticed, but there's a bump on each side of the cheek. So check that out sometime in the mirror, with a flashlight. You'll see that bump. Now, you probably know it's there because occasionally you accidentally bite that bump. And what happens after you bite the bump? Well, it swells up. And then what happens after it swells up? Well, it's bigger now, so you bite it again, and it swells up again. It really hurts. No fun. But that is the opening to the parotid duct. Okay? If you've ever eaten something sour or thought about eating something sour, sometimes you'll get this pain on the sides of your jaw, and that's the parotid gland trying to secrete some extra saliva into the mouth, either because of the sourness or expecting that there's going to be some sourness. Okay, so parotid gland here. Here is the submandibular gland. Again, it's kind of at the angle of the mandible. That's where we have that duct that goes to the front of the, underneath the tongue. And then we have the sublingual salivary glands, and they have tiny little ducts coming out just along the sides of the tongue. Okay. Now the pharynx and the esophagus. The pharynx, if you remember, is throat. The nasopharynx, as we mentioned before, is not part of the digestive system. It is part of the respiratory system. The oral pharynx is part of the digestive system and the respiratory system. So it transmits food normally. And then the laryngopharynx, also part of the respiratory system and digestive system, so it transmits food normally. Now, they're mentioning normally here because sometimes in order to feed a patient, we might have to put a tube down into their stomach, a feeding tube. And so that would be a nasogastric tube. So that nasogastric tube would go down the nasopharynx, past the oral pharynx, past the laryngopharynx, down the esophagus, and into the stomach. Now, the esophagus transports food from the pharynx to the stomach, and it passes through kind of a hole, an opening in the diaphragm called the esophageal hiatus. And sometimes that can become weak. And so some of the stomach can come up through that esophageal hiatus, and we call that a hiatal hernia. And then the sphincters of the esophagus, we have the upper esophageal sphincter and the lower esophageal sphincter. And we typically call that lower esophageal sphincter the LES. LES. And again, that can sometimes become weak, either from gas pushing on it, or alcohol will cause it to relax. So will nicotine, caffeine, chocolate. So all of those things can relax that lower esophageal sphincter and allow stomach acid, fats too, forgot to mention fats, that can cause stomach acid to splash up onto the esophagus, and the patient can wind up with GERD, or gastroesophageal reflux disease. Now, with swallowing or deglution, there are 3 phases. You have the voluntary phase, which there's a bolus of food moved by the tongue from the oral cavity to the pharynx. There's the pharyngeal phase, which is a reflex. The upper esophageal sphincter relaxes, elevates the pharynx, opens the esophagus, and food gets pushed into the esophagus. And then we have the esophageal phase, also a reflex. The epiglottis is tipped posteriorly. The larynx is elevated to prevent food from passing into the larynx. And so looking at this picture, we can see the different phases. Here's the voluntary phase, again, where the food is chewed and the bolus of food is being pushed by the tongue back into the pharyngeal area. So now we're in the pharyngeal phase, and you can see that it's going to be in the oral pharynx and working its way down into the laryngeal pharynx, and the esophageal sphincter, the upper esophageal sphincter is going to relax as the bolus of food comes down. It's going to then push down on the epiglottis to seal the larynx so that food does not go there. And it directs the food back into the esophagus. And then we're finally in the esophageal phase. And once the food passes the larynx, the epiglottis opens back up, and the bolus of food is then propelled down to the stomach, where the lower esophageal sphincter will relax, and the food will, or the bolus of food, I should say, will empty into the stomach. Stomach anatomy. The openings, we have the gastroesophageal opening right here, and that is from the esophagus to the stomach. And then we have the pyloric opening right here, and this is from the pyloric region of the stomach into the duodenum. The regions of the stomach, we have the cardiac region right here. Now think about cardiac region. Cardiac, what do you normally think of? You think of heart. Well, if this lower esophageal sphincter relaxes, which is near the cardiac region, what are you going to get? Heartburn. So again, that's how I remember. Okay, I get heartburn, heart, cardiac. Oh yeah, that's the cardiac region right there. The fundus is this part right here, the rounded portion. I'm going to skip over to the pyloric region. So this is the pyloric region, right in here. So between the fundus and the pyloric region, we'll find the body. And so looking at the layers, we have the serosa or visceral peritoneum, and that's going to be the outermost layer here. The muscularis, again, we have three layers. We have the outer longitudinal layer, the middle circular layer, and the inner oblique layer. Next, we have the submucosa, and then finally, the mucosa. Now, rugae, as I pointed out before, are folds, and we find those when the stomach is empty. And a lot of times I'll ask, what's the function of those folds? And you might think, well, that increases surface area. Well, normally that answer would be right for most things, but in this case, those folds are simply to allow the stomach to contract, and it allows the stomach to stretch out quite a bit. So they really don't provide for surface area. It just allows the stomach to stretch. Now here, if we look at a histological piece or chunk of the stomach under the microscope, we'll see these gastric pits. Okay, gastric pits. And these are going to be openings for the gastric gland. Now the cells it contains are the surface mucus cells. Okay, so surface mucus cells. Then we have the mucous neck cells. We have the parietal cells, which makes hydrochloric acid, and also something called intrinsic factor. Intrinsic factor is important because this is what allows you to absorb vitamin B12. If you don't make enough intrinsic factor, or you don't make any intrinsic factor, then you have a condition called pernicious anemia, in which case you'd have to give yourself vitamin B12 shots. And then finally, we have chief cells, and chief cells make pepsinogen. The best way to remember that is think of a chief of some kind, and think of that chief drinking a Pepsi. And then we have some endocrine cells. And these are going to secrete regulatory hormones. Now, think about this for a second. The hydrochloric acid will break down proteins. Well, what do you think your stomach is made out of? It's made of protein. So how does the stomach protect itself and keep it from breaking itself down? And there is a condition where it does get to the cells and the tissue and starts to break it down, and that would be called an ulcer. But it's basically these mucus cells, the mucous neck cells and the surface mucus cells that provide that mucus layer, and that does help to protect the stomach. Now, there is a bacteria that can erode through that mucus layer and get to the stomach itself, and that is called Helicobacter pylori, or H. pylori. And it was first discovered by this one doctor, and I should remember his name, but and if you get a chance, look up the discovery of H. pylori. It's a very interesting story. But this doctor who was doing the research discovered the H. pylori within ulcers. And it's a bacteria that's normal to soil. But the thing was this an opportunistic bacteria that you've already got an ulcer, and so it saw the opportunity to start to grow in that area? Or did it actually cause the ulcer? Okay, so he experimented on himself. He drank some liquid containing the H. pylori, and before that, he was scoped to make sure that he had no ulcers, had no H. pylori. Then he drank the liquid, And then he started to get symptoms of an ulcer. He was scoped again, and sure enough, an ulcer was developing. They cultured it, and the H. pylori was found. Now, you would think that would be a great thing, and he did go on to win a Nobel Prize for medicine because of this discovery. But he hit upon a lot of resistance, even threats. And you would think, well, wait, this is science. He did the experiments. He showed his results. Okay, and but that's not the way the real world works. He did run into a lot of opposition and a lot of blowback because of it. But eventually, what he showed proved right, and that changed the way we treat ulcers now. Instead of just giving an antacid of some type or a proton pump inhibitor like Prilosec or Nexium, or an H2 blocker like Zantac, which has now been pulled off the market because of contamination. Instead of that, or I should say not instead of that, but in addition to that, we now give an antibiotic to help kill the Helicobacter pylori. And so now let's take a look at a little video about hydrochloric acid production.
Hydrochloric acid is produced in parietal cells through a complex series of reactions. Carbon dioxide diffuses into the parietal cell, and the enzyme carbonic anhydrase catalyzes a reaction between the carbon dioxide and water to form carbonic acid. Carbonic acid dissociates into bicarbonate ion and hydrogen ion, and the bicarbonate ion is transported back into the bloodstream. An ion exchange molecule in the plasma membrane exchanges bicarbonate going out for chloride coming in. The hydrogen ions are actively transported into the duct of the gastric gland, and the negatively charged chloride ions diffuse with the positively charged hydrogen ions. Potassium ions are counter-transported into the parietal cell in exchange for hydrogen ions. The net result is production of hydrochloric acid in the parietal cells and its secretion into the duct of the gastric gland.
And so the stomach has different phases of gastric secretion. We have the cephalic phase, which we see over here. We have the gastric phase, which we see right here. And then we have the intestinal phase, followed by that. And so let's take a look at a little video about that.
Regulation of stomach secretion is divided into three phases: cephalic, gastric, and intestinal. In the cephalic phase, the taste or smell of food, tactile sensation of food in the mouth, or thought of food sends nervous impulses to the medulla oblongata. These impulses cause parasympathetic neurons via the vagus nerves to stimulate secretion of hydrochloric acid and pepsin in the stomach. The parasympathetic stimulation also results in secretion of gastrin from the lower part of the stomach. This hormone travels through the bloodstream and further stimulates hydrochloric acid and pepsin secretion in the upper and middle parts of the stomach. In the gastric phase of gastric secretion, food has entered and distended the stomach. This distension activates a parasympathetic reflex via the medulla oblongata and also has a direct stimulatory effect on the gastric glands. The result is continued secretion of hydrochloric acid and pepsin. In the intestinal phase of gastric secretion, chyme has entered the duodenum, so gastric secretion is no longer needed. When the chyme contains lipids from the digestion of fats or contains enough hydrochloric acid to bring its pH below 2, gastric secretion is inhibited. The lipids and hydrogen ions inhibit gastric secretion by three simultaneous actions. First, they cause impulses to go to the medulla oblongata to decrease parasympathetic stimulation of the gastric glands. Secondly, they set up local reflexes via neurons in the wall of the gut that decrease gastric secretion. Thirdly, they cause the release of three local hormones which travel via the circulation to the gastric glands and inhibit their secretion.